Hello everyone. So this video is the continuation of the protein energy malnutrition. We were discussed that there are 10 steps in the management of the complicated severe acute malnutrition. So these are the 10 steps. So that is the first is we have to treat the hypoglycemia, then hypothermia, then treatment of the dehydration. Fourth step is treatment of the electrolyte imbalance, and fifth one is treatment of the infections. And the sixth is treatment of the micronutrients. So we have to supply the adequate micronutrients, then initiate the feeding is seventh step, and catch up growth is an eighth step. Sensory stimulation is ninth step, and the prepare for the follow up is the 10th step. So, uh, and all these stages, there will be a correction in this last video. That is, the rehabilitation phase is only for the 2 to 6 weeks, not for the 2 to 26 weeks. It is for the 2 to 6 weeks. So, uh, there are two phases for this management. There is stabilization phase and rehabilitation phase. And this day 1 to 2 is called the exact stabilization phase, and day 3 to 7 is called the recovery, the transition phase. And this is the rehabilitation phase for the 2 to 6 weeks. And all of these steps, except for the catch-up growth and the prepare for the follow-up, started immediately at the day 1. And the hypoglycemia, hypothermia, and treatment for the dehydration, which for the only for the day 1 to 2, and the electrolyte imbalance is corrected for throughout the treatment. And the also infection we should be treated for the day 3 to 7. That is first week we have to treat for the end through the entire first week we have to treat for the infection and the initiate feeding. And then the sensory stimulation is also sensory stimulation, the micronutrient supplementation, and electrolyte imbalance correction is required throughout the treatment. And the micronutrient supplementation, the initial stabilization phase, that is without iron, and in the rehabilitation phase it should be administered with iron. And the catch-up growth and the prepare for the follow-up is initiated only after the first week of the um, treatment phase. That is, after the stabilization phase only the catch-up growth and prepare for the follow-up is started. That is during the rehabilitation phase, that is weeks 2 to 6. So these are the 10 steps in the management of the complicated severe acute malnutrition. So this is the step in the managed first step, that is to treat the hypoglycemia. The hypoglycemia, which can be symptomatic or asymptomatic. The symptomatic hypoglycemia, which is manifesting as lethargy, unconsciousness, seizures, peripheral circulatory failure, or the hypothermia, that is more common in the marasmus, where energy stores are depleted or when the feeding is infrequent. So the hypoglycemia will be symptomatic in the marasmic child. And the so in the hypoglycemia, which means blood glucose level less than 54 milligram per deciliter or the 3 millimole per liter. If the blood glucose cannot be measured, we can assume it as the hypoglycemia. Hypoglycemia, hypothermia, and infection, which generally occurs as triad. So the triad of the severe acute malnutrition is the hypoglycemia, hypothermia, and infection. So how will you treat this hypoglycemia? That's we have the asymptomatic hypoglycemia. There is no features of the hypoglycemia. We have to give the 50 ml of the 10 percentage of glucose or sucrose solution orally or by the nasogastric tube, followed by the first feed with the starter F75 every 2 hourly, day and night. And if in the case of the symptomatic hypoglycemia, we have to give 10 percentage dextrose IV 5 ml per kilogram. That is followed with the 50 ml of 10 percentage dextrose or sucrose solution by the nasogastric tube, feed with the starter diet every 2 hours, day and night, and start appropriate antibiotics. So these are the treatment option for the asymptomatic hypoglycemia and symptomatic hypoglycemia. Then how will you prevent the hypoglycemia? Feed 2 hourly starting immediately. By this we can prevent the hypoglycemia. So these are all the tables I am taken from the new edition OP guide. So for writing the essay questions, this should be enough. This is the summary of the management of severe acute malnutrition. The next step is the treatment of the hypothermia. If the rectal temperature is less than 35.5 degrees Celsius or 95.5 degree Fahrenheit, or actually temperature less than 35 degrees Celsius or 95 degree Fahrenheit, is known as the hypothermia. Always measure blood glucose and screen for the infection, the presence of hypothermia, because in the severe acute malnutrition, hypothermia, hypoglycemia, and the infection which occurs as a triad. So if one of them is present, we have to look for the another also. Then how will you treat the hypothermia? The clothe the child with the warm clothes. Ensure that the head is also covered with a scarf or cap. Provide heat using overhead warmer, skin contact or heat convector. Avoid rapid rewarming as this may lead to disequilibrium. And feed the child immediately and give appropriate antibiotics. Then how will you prevent the hypothermia? Place the child's bed in a draught-free area. Always keep the child well covered. Ensure that head is also covered well. Place the child in contact with the mother's bare chest or abdomen, that is skin to skin contact. Feed the child 2 hourly starting immediately after admission. By this, we can prevent the hypothermia from developing. The next is to correct the dehydration. It is difficult to estimate dehydration status accurately in the severely malnourished child. Assume that all the severely malnourished children with the watery diarrhea have some dehydration. Low blood volume or hypovolemia can coexist with edema. Uh, and the treatment of the dehydration, which include use reduced osmolarity ORS with the potassium supplements for the dehydration and maintenance. Amount depends upon how much the child wants, volume of the stool loss, and whether the child is vomiting. Initiate feeding within 2 or 3 hours of starting rehydration. Use F75 formula on the alternate hours along with the reduced osmolarity ORS. Be alert for the signs of overhydration. Then how will you prevent the dehydration? Give reduced osmolarity ORS at 5 to 10 ml per kilogram after each water stool to replace the stool losses. If breastfeed, continue breastfeeding. Initiate refeeding with the starter formula. Then we have to treat the electrolyte imbalance throughout the treatment of the hospitalized treatment for the severe acute malnutrition for the complicated SAM. Give supplemental potassium at 3 to 4 milliequivalent per kilogram per day for at least 2 weeks. On day 1, give 50% magnesium sulfate, that is equivalent to 4 milliequivalent per ml intramuscularly once. Thereafter, give extra magnesium, that is 0.8 to 1.2 milliequivalent per kilogram daily. Excess body sodium exists even though the plasma sodium which may be low, that is decreased salt in diet. And then the next is we have to treat the infection. That is fourth step is to treat the infection. That is multiple infections which are common, and assume serious infection, and every infection which happens with severe acute malnutrition is assumed as serious infection and treat according to that. Usual signs of infection such as fever are often absent in the case of the severe acute malnutrition. So it should be kept in mind. Majority of the bloodstream infection which are due to the gram-negative bacteria, hypoglycemia and hypothermia, which are markers of the severe infection. So these are triad, that is hypoglycemia, hypothermia, infection, which are the triads in the severe acute malnutrition. So the hypoglycemia, hypothermia, which are the markers of severe infection. The treatment which consists of treat with the parenteral ampicillin 50 milligram per kilogram dose 6 hourly for at least 2 days, followed by the oral amoxicillin 50 milligram per kilogram 8 hourly for 5 days, and gentamicin 7.5 milligram per kilogram or amikacin 50-20 milligram per kilogram intramuscularly or intravenously once daily for 7 days. If there is no improvement occurs within 48 hours of treatment with these antibiotics, change to IV cefotaxime, that is 100 to 150 milligram per kilogram per day 8 hourly, or ceftriaxone, that is third generation cephalosporins 50 to 75 milligram per kilogram per day for 12 hourly. And if other specific infections which are identified, give appropriate antibiotics according to that. Then how will you prevent the infection? We have to follow the standard precautions like hand hygiene, give measles or MR vaccines if the child is greater than 6 months and not immunized, or if the child is greater than 9 months and have been vaccinated before the age of 9 months. Then the next step is the micronutrient supplementation. Use up to twice the recommended daily allowance of various vitamins and minerals. That is, twice of the recommended daily allowance we should be supplied. On day 1, give vitamin A orally. If age is greater than 1 year, we give 2 lakh international unit, and age is 6 to 12 months, give 1 lakh international unit, and age is 0 to 5 months, give 50,000 international unit. And folic acid also supplemented, that is 1 milligram per day, give 5 milligram on day 1, and the zinc is 2 milligram per kilogram per day, and the copper 0.2 to 0.3 milligram per kilogram per day, iron 3 milligram per kilogram per day. Once child starts gaining weight, after the stabilization phase only we have to give the iron, that is after stabilization phase, that is after first week, we have to give the iron only. Then the next step is to initiate the feeding. Start feeding as soon as possible as frequent small feeds. If unable to take orally, initiate the nasogastric feeds. Total fluid recommended is 130 ml per kilogram per day, reduced to 100 ml per kilogram per day if there is severe edema. If continue breastfeeding, then start with the starter feeds every 2 hourly. If persistent diarrhea is there, give a cereal-based low lactose starter diet. If diarrhea is continuous on low lactose diet, give lactose-free diets. Rarely it is needed. So that is the initiate feeding. Then next step is the catch-up growth. That is once appetite returns in 2 to 3 days, encourage higher intakes. Increase volume offered at each feed and decrease the frequency of feeds to 6 feeds per day. Continue breastfeeding and make a gradual transition from the starter to catch-up diet. Increase calories to 150 to 200 kilocalorie per kilogram per day and proteins to 46 kilogram per kilogram per day. Add complementary foods as soon as possible to prepare the child for the home foods at discharge. So catch-up growth is only after the stabilization phase. Then sensory stimulation. A cheerful, stimulating environment, age-appropriate structured play therapy for at least 40 to 30 minutes per day, age-appropriate physical activity as soon as the child is well enough, and tender loving and care should be provided. Then last step is the prepare for follow-up. It is also after the stabilization period. That is after 1 week. Primary failure to respond is indicated by failure to regain appetite by the day 4, failure to start losing edema by the day 4, presence of edema on the day 10, and the failure to gain at least 5 gram per kilogram per body by day 10. So these are the primary failure to respond features. Then secondary failure to respond is indicated by failure to gain at least 5 gram per kilogram per day for the consecutive days during the rehabilitation phase. In that cases, we have to prepare for the follow-up. So these are all about the treatment for the severe acute malnutrition, complicated severe acute malnutrition, that is hospitalized. 10 steps are there. So we have to study this in detail, and if any question asked regarding the management of the complicated severe acute malnutrition, we have to write it as there are 10 steps in the management of the uh, complicated severe acute malnutrition. So according to that, we have to write the 10 steps, and that table, that is the arrow table, we should be also score more marks. Oh, that's all about the hospital management of the severe acute malnutrition. We have to remember in mind that hypoglycemia, hypothermia, infection, which are occurs as triad. So if there is any one of them mixed present, we have to look for the other, and we have to prevent other conditions also. Then during the treatment of the dehydration, if there is any signs of shock, this is the algorithm for the treatment of the shock in case of dehydration. If the severe acute malnutrition with the shock is present, that is the patient is lethargic or unconscious and has the cold hands plus slow capillary fill greater than 3 seconds or weak or the fast pulse, weigh the child, give oxygen, keep the child warm, injection 10% dextrose 5 ml per kilogram, injection ringer lactate in the 5% dextrose or the half normal saline in the 5% dextrose 50 ml per kilogram in the 1 hour. Then also assess the pulse and respiratory rate every 5 to 10 minutes. And if the child improves with these measures, repeat the same IV fluid of 50 ml per kilogram over 1 hour, ORS by nasogastric tube starter formula. And if the child is fails to improve, assume it is septic shock and give maintenance fluid 4 ml per kilogram per hour, antibiotics and dopamine. And if the child's condition is deteriorates, the signs of overhydration is there, stops fluids and reassess. And again, after that, assume septic shock and treat accordingly, give maintenance fluid 4 ml per kilogram per hour, antibiotics and dopamine. And in the case of treatment of the infections, if there is any malaria or is detected, antimalarials are used. And if there is any TB is diagnosed or strongly suspected, antituberculous therapy should be administered. And also, the prevention is by the strict hand hygiene and measles vaccination if the child is greater than 6 months and immunized, or 9 months immunized before 9 months of age. So this is the initiate feeding. Step 7. In the day 1, 1 to 2, frequency is 2 hourly. We have to give the 11 ml per kilogram per feed. And on the day 3 to 5, we have to frequently give 3 hourly, 60 ml. On 6th day onwards, we have to the frequency is 4 hourly and the 22 ml. And during the catch-up growth, we have to give the catch-up formula, replace the starter formula with equal amount of catch-up formula for 2 days, that is have 100. Then on third day, increase each successive feed by 10 ml as long as child is finishing the feeds. Continue increase the amount till some food remains uneaten. After this, give 150 to 220 kilocalorie per gram per day and 4 to 6 gram per kilogram per day of protein. Switch to complementary feeding as soon as possible to prepare the child for the home foods on discharge. And the ready to utilize therapeutic food which can be used, amylase rich foods which can also be used, and the kisti, dahlia, banana, curd, rice, chickpea, and sukki which can also be used. Then we mention a diet called the F75. The recipe for the F75 is fresh cow's milk 30 ml, then sugar, the puffed rice or the cereal flour, vegetable oil, water to make, and it gives 75 kilocalories, hence the name F75 formula. Then 0.9 gram protein and 1 gram lactose. Kept at room temperature and for the 6 hours and in the fridge for 24 hours. And the recipe for the 100 is fresh milk is 75 gram, sugar is 2.5 gram, cereal flour, puffed rice is 7 gram, vegetable oil is 2 gram, and water to make is 100 ml. Then sensory stimulation is by the providing tender loving care, a cheerful stimulating environment with a maternal and involvement. The structured play therapy for the 40 30 minutes per day. Each play session to include language and motor activities and activities with the toys, local songs and stories to facilitate the language development. Passive mobilization of immobile children, and mobile children should be encouraged to run, tumble, toss, etc. These are the steps of the sensory stimulation. Then the step is prepare for the discharge and follow-up. Average duration of the hospital stay in 2 to 3 weeks, may take longer. Child and mother should be prepared for the home management. Deworming of the child with a single dose albendazole. A&M workers in the area should be informed about the patient. All the children to be followed at home till weight reaches the -1 standard deviation. The criteria for the discharge are the child, if the weight for height is less than -1 standard score, eating adequate and nutritious home food, vitamins and minerals supplemented, infections and associated conditions treated, full immunization is program is started. And the case of mother able to take care of the child, able to prepare the appropriate foods and feeds for the child, has been trained for the sensory stimulation, knows common problems and danger signs. And these are the criteria for discharge. That is both child and mother criteria. And follow up at 1, 2, and 4 weeks, and then monthly for 6 months, and 6 monthly for the 2 years. And early discharge is provided when the community-based care is strong. Weight for height or the length at least greater than or equal to 2 standard score deviation plus no edema for the 2 weeks. Mid-upper circumference is greater than or equal to 12.5 centimeter with no edema for 2 weeks. Good appetite and completed antibiotic treatment. Weight gain at least 5 gram per kilogram per day for the 3 consecutive days, and immunize the child. If caretaker is sensitized, and ASHA workers can take regular follow-up if we have to early discharge the patient. So this is the failure to respond if good weight gain is greater than 10 gram per kilogram per day, continue same treatment. If moderate weight gain is there, that is 5 to 10 gram per kilogram per day, check whether intake targets are being met or if the infection is overlooked and the child is recovered when he reaches -1 standard score of median WHO gross standards. Criteria for the failure to respond is we already discussed that. If there is poor weight gain, which indicative of the inadequate feeding, in untreated infection, HIV infection, and psychological problems. So the next topic, as a small topic, is severe acute malnutrition in the children less than 6 months of age. We already told that usually according to WHO, it happens only during the 6 months to 60 months of age. But if it has happened less than 6 months of age, if there is any lower birth weight baby or if there is any severe diarrhea is present, that is indicated if the less than 6 months of age. The criteria for the admission is too weak to suck independently. The weight for length is less than -3 standard deviation or visible severe wasting or edema of both feet. The management of complications same as of the older children. Initial free feeding, continue or the reinitiate the breastfeeding if possible. Supplemental sucking technique to augment the enteral breastfeeding. Withdraw once breast milk output adequate and adequate weight gain. If there is no prospect of breastfeeding, F75 in the acute phase but without cereals. Rehabilitation phase, breastfeeding and if not possible, F100 but diluted in the 135 ml water. On discharge, breastfeeding or the undiluted animal milk with the cup and spoon. Formula feed only if affording adequate supplements to mother also. And in our states also there will be nutritional rehabilitation center where the patient with SM which are admitted and managed. The children are admitted as per the defined criteria, investigated and treated using fixed protocols. Medical as well as nutritional care is given in the nutritional rehabilitation centers. After discharge from the nutritional rehabilitation center, the child continues to be in the rehabilitation program till attainment of the predefined discharge criteria for the program. Apart from the medical care, special emphasis is given to feeding, training of the mothers, counseling and support to caregivers. The services provided by the nutrition rehabilitation centers are 24-hour care and monitoring of the child, treatment of the medical complications, therapeutic feeding, sensory stimulation and emotional care, addressing contributing factors for the severe acute malnutrition, counseling about the feeding and hygiene, showing preparation of the energy-dense food with the local ingredients, follow-up care of the children. These are the services provided by the nutritional rehabilitation center. Then the prevention of the severe acute malnutrition. How will we prevent the occurrence of the severe acute malnutrition? The national health programs for the severe acute malnutrition prevention management will be first one is the integrated. There are different national health programs. One of them is the integrated child development scheme, that is ICDS scheme. The supplemental feeding of mother and child, immunization of pregnant women and infants, and health checkups. These are under the integrated child development scheme. And there are different groups. There is children 6 to 72 months of age and SAM 6 to 72 months of age, a pregnant and lactating mother. So in this different age groups, we have to supplement the feeding. Then next program is the Mission Balam Sugam, that is establishment of the Bal Shakti Kendra, Bin Bal Seva Kendra and Bal Sanjeevani Kendra. Next is the portion, 3-year mission to reduce the malnutrition, reduce stunting at 2% per year, reduce undernutrition 0 to 6 years children at 2% per annum, reduce prevalence of anemia in 6 to 59 months or children, women and adolescent girls at 3% per year. So these are the national level programs to prevent the SAM and also for the management integrated ICDS scheme, Mission Balam Sugam and portion. And for the prevention, there will be individual level action, that is at the level of mother, child, and adolescent girls. At the level of mother, childbirth spacing, prevent young mothers' pregnancies, family planning, iron, folic acid supplementation, nutrition during pregnancy. And for the child, breastfeeding within 1 hour after birth, exclusive breastfeeding till 6 months, appropriate complementary feeding, prompt the treatment of diarrhea and pneumonia, promote balanced diet, vaccination, hand washing. In the adolescent girls, look for the nutrition parental education. So that is all about the topic of severe acute malnutrition. In that, we have to the most of the essay questions which are asked from this severe acute malnutrition about the definition, that is that criteria, that is WHO criteria and the IAP criteria, that is under the definition, then etiology, then pathophysiology, the edema, then difference syndromic, that is marasmus, then Kwashiorkor, difference between that. Then we have to look for the complicated and uncomplicated uh, uh, SAM. So we are forgot to discuss about the uncomplicated SAM. So uncomplicated severe acute malnutrition, which are usually managed at home. The home management, which include nutritional therapy, that is initially home food or the ready to use therapeutic food, then home food, and then continue breastfeeding. Provide 175 kilocalorie per kilogram per day, feed 6 to 7 times per day, and we have to give drugs also in the home-based management, that is amoxicillin for the 5 days, mega dose of vitamin A if signs of deficiency is there, albendazole 400 milligrams single dose, and vaccination. And the third step is sensory stimulation, play therapy, and tender loving care. Supervision by the health workers, that by the ANM or the ASHA, initially daily and then twice a week. Monitoring and growth assessment weekly. So these are the home management for the uncomplicated severe acute malnutrition. So we almost cover entire um, severe acute malnutrition topic, that is both management of this complicated and uncomplicated severe acute malnutrition, and also moderate acute malnutrition is also treated as the home-based management. So that's all about the severe acute malnutrition. Thank you.